questions there, we'll answer. And yeah, chat, do say hi. So everybody coming in, welcome, welcome. Do say hi in the chat and say, yeah, where you're connecting from. Also lovely if you say where you are in terms of if you're just taking the course, where you are, if you completed in practice, if you're already seeing clients with IBS. We'd really like to know who's with us today and what your level of interest, experience, expertise is with regard to therapy, but particularly with regard to this particular issue. Hi, Candy coming from France, Madeline from Warwick. And thanks, Chris, Lindsay, Monica, Aisha, Mehmet. Hi, welcome. Leanne, welcome. And Sarah in Worcester, that's fantastic. So it's 1 o'clock. Okay, fantastic. From Sweden, Gothenburg. Wonderful, wonderful. So let's officially start here and say, welcome everybody to this webinar with Dr. Elena Eliadou, who is a consultant gastroenterologist and also Hypno-CBT therapist, cognitive behavioral hypnotherapist. And we're going to be discussing irritable bowel syndrome, the different treatments for irritable bowel syndrome, particularly not just gut-focused hypnotherapy, particularly Hypno-CBT, a more integrative and also personalized, tailored approach for working with IBS. And we're going to also hopefully cover a lot of material that's going to provide a lot of helpful information for those who are working with it, suffering with it, correct some myths, I think, out there. I think that's part of the plan. And we're here also to answer your questions. So we'll have plenty of time for Q&A too. So welcome. And yes, do please say where you're connecting from. And also, if you've not decided to take the course yet, but you're sort of interested and you're joining, do let me know about that too. Very interesting to have you all here. It is being recorded. You will be able to get the recording afterwards if you have to leave early. So don't worry. We're going to run hopefully 2 hours, maybe a little bit less, hopefully not over. Okay, so let's get started. First, for everybody, I'm Mark Davis. I'm the director and principal at the UK College of Hypnosis and Hypnotherapy, and I'm really delighted to be hosting the webinar here with Dr. Elena. And please, I want to do a long introduction and find Dr. Elena's story in a minute, but please do introduce yourself, where you're connecting from, Elena.
So yeah, I'm Dr. Elena Eliadou. I'm a gastroenterologist. So I'm connecting from Manchester, and I've done the diploma last year. So yeah, quite new to the business, but yeah, here we go.
And enjoying applying it into your specialist domain.
Yes, of course. I think it's quite transformative, I think. So it's always nice to be able to use skills that you learn. So yeah, I'm enjoying it so much. Yeah.
Okay. Well, I think what I'd like to do, I want to find out a little bit more for everybody here, your journey into medicine, then your specialization into gastroenterology, and then how your interest into, I'm assuming it was first hypnosis, and then into deciding to do this particular training. But let's sort of wind back in time and
Sure.
Originally, where are you from and how did you get into medicine and then gastroenterology?
So I'm originally from Cyprus, so a small island in the Mediterranean. So quite early on, I was interested in the medical aspect. So I did a lot of experience as a kid in hospitals and volunteering.
Oh, wow.
So yeah, so I came to the UK and I trained in UCL and Royal Free. I did further medical exams and training. I did my MRCP and then decided to go to New Zealand. So I did more training there because I didn't accredit the training in the UK. And I decided to do my specialist training in gastroenterology there. And then
why gastroenterology? Why not?
I was always, I think, as being a junior doctor, obviously you're quite influenced sometimes by who you work with and your mentors. And I had great models of consultants that I worked for, and they were gastroenterologists. I was also interested in the whole gut, and it's a huge specialty, and the fact that you can even niche down specifically. So yeah, I was just fascinated by the whole thing, and having had good role models, I think that really inspired me to do gastroenterology.
And was it a very, when you were studying it, I mean, some areas are obviously much more developed in terms of all the research and treatments, and other areas are kind of more, neuroscience as a whole, much newer area. So, I mean, in terms of how mature as an area was it when you were getting into it, gastroenterology? Because it's evolved, I imagine, since you started, yeah?
It has been evolving, yeah. And I think with IBS, it has evolved significantly because it was always called a functional problem. It was a somatizing problem in the beginning, then it was a functional problem. And there was a lot of, even as doctors, we didn't understand the problem very well. And I think we're still learning a little bit more, but I think the more the developments are happening now, it's expanding rapidly. And it's very hard to be on top of everything, especially in gastroenterology, because it's almost like, I don't know how many organs you have to look after, but we do have like subspecializing. So you can have the liver specialists that do just the liver. You've got the pancreatic and the pancreatic duct and other organs that specific people do that. And then you've got luminal, which is what I started with is a generalized saying basically it's anything from your gullet down to your anus. And even with that, you can subspecialize. And initially, my interest was in inflammatory bowel disease. So I did some research on that. And that was why I came back to the UK to do more tertiary exposure. So in more specialized centers to do more research. And then I decided that I think going through quite a lot of research, I was always fascinated about the fact that even when you treat people with inflammatory bowel disease, there was a huge proportion of them that were still having significant symptoms and disturbing, like the quality of life was disturbed. And we always put it down to stress, but I just felt uncomfortable because I didn't know how to explain to people what exactly was going on because I couldn't understand it myself. So that's always fascinated me a little bit, but also the aspect of hypnosis and hypnotherapy, I was always interested in that. And having had, obviously we knew that Prof. Warwell had a lot of influence in how you treat functional disorders with hypnotherapy, but we never get taught that in medical schools, or you never have experience with that. So I was always intrigued about what does that mean. So I did decide at some point to take after COVID, and I think obviously the stresses of work have become quite significant, and also the frustrations with the system and short appointments, and feeling that I was a little bit starting to detach a little bit from, you become less empathetic sometimes because you can't, in a short time that you have, you can't really address everyone's psychological problems. You're never taught to do that in a way. So I decided to step back and understand a little bit about the psychology, because I thought that was quite important. And initially I thought I would do a psychology degree, but I came across the diploma and I thought, okay, that's interesting. And we had some question and answer in a webinar, I think. So I was like, okay, yeah, I can see how this I can apply further on. And yeah, doing that, I just loved it. And now, yeah, I can see exactly how I can apply it.
Wow. Okay. Well, I was going to ask lots of questions about your journey points there, but you gave us the overview there. Fantastic. I want to come back and ask some questions about, well, one, it seems to me that you are. There's an interview with Robert Melzack about how he got involved in gait control, pain, and he just said, pick a difficult problem. Don't pick an easy problem. But I get that sense with you that you're picking, there's areas of the gut, cancer in the different parts or whatever, or other, I don't know all the things, but are there areas that are more specific? We've got an organic issue. We can measure it. We can design a treatment. Da, da, da. But no, you want to pick a hard problem, like one that no one. Is that right in terms of like, yeah, there are areas that because this isn't clear cut and the explanations haven't been good and the treatments don't seem to, is that?
Yeah, and I think the more I got into it, the more fascinated I am about how complex it is and how we minimize the problem where actually it's quite complicated. And I think if we apply um, all the techniques that we know, we can actually personalize the care so much and give someone a completely, different outcome, because there's a lot of people that suffer with IBS and they shouldn't suffer. I feel that we're letting them down.
Hmm. Yeah, I know, and I talked Professor Peter Wall. I had a long chat with him about this the same way. But let's come back to a little bit also the way in which medicine was understanding it. So when you were, this idea of it being a somatization,
Mhm.
can we explain the different ways in which medicine has tried to understand it, and then how it's starting to understand it now? I think perhaps that's an interesting journey to see, and definitely people aren't all up to speed with it, and they've some of those old
Sure.
models go right.
So I think obviously we knew there was a problem with IBS. It wasn't called IBS at the time, but it's been, I think, quite early on from the 1900s. And I think in the beginning it was called spastic colon because they just couldn't define it in a different way. And it was just because everything was normal and they just couldn't explain it. But then it was called somatizing disorder, and it had some criteria around that. But then, as the medical field evolved, there was the Rome Foundation that has been created, where they
Mhm.
were initially looking at these disorders and doing a lot of research, and they started developing some criteria in how to diagnose IBS, and they have gone through different changes of the criteria. But the huge change that happened was in 2016 when they redefined IBS instead of a functional disorder, a disorder of the gut-brain interaction. And obviously, there's a huge aspect of that, but IBS is mostly the diagnostic criteria for it is that you have to have abdominal pain and changing your bowel habit or stool frequency and consistency, and also the pain has to be related to when you go to the toilet and things. Um, so those are the specific, obviously, for IBS. But yeah, the diagnosis of being a disorder of the gut-brain interaction, I think, is an important point because it does put the brain as part of the problem.
Problem.
Um, yeah,
Can we wind back though a little bit because I want to, when we talk about somatization disorders, I mean, my understanding is that's quite influenced by kind of Freudian ideas that these disturbances here reflect kind of inner disturbances being expressed in the body.
yeah,
Is that
yeah,
right? So that's
exactly.
been quite a strong kind of psychiatric, psychoanalytic formulation of the problem. Um,
Yeah.
and I does that, and then it moved to functional, and I want to understand the difference between functional and gut-brain axis because I don't quite understand if that's how that's different. But let's talk about that because that idea that this is an expression that these different things that people have, particularly what we might call psychosomatic. It was classed as a psychosomatic disorder, like a skin eczema and stress-related psychosomatic disorders, but very often the idea originally, even before the stress model came, I think more that it's a sort of an inner conflicted drive model from Freudian. Is that correct?
Yeah, well, that's a myth. So obviously we need to address the myth later on. But yeah, stress is not a cause of IBS. It can drive IBS. So
Yeah.
that is a what so when people say it's all stress related, it's not. And we're gonna go into the complexities of IBS, but stress is one of the drivers of IBS. So it can maintain things.
But the previous idea, the Freudian idea, was this that there's an internal conflict, and this is the expression of the internal conflict. Um,
I'm not sure about the Freudian
Freudian
ideas, but yeah,
because I mean, what the idea that you need to treat the root cause, not the symptoms. This is kind of one of the things that still I think lingers a lot in certainly in sort of some areas of sort of psychiatric and psychoanalytic thinking. So, but that idea that this is the expression of some internal conflict in the psyche, I think that's done and dusted. then it's stress related, and then we're seeing much that within a bigger picture, though it's not just stress related.
Yes. Yeah.
So explain for everybody quickly, what does a functional disorder mean? And then what's the difference between, see, I think gut-brain axis is a type of functional disorder, but maybe I'm wrong. So could you explain, kind of give a definition of functional disorder?
So functional disorder is basically when tests are normal. So the gut has a structure and a function. So when we have a problem with the structure, it's either it's an inflammation or cancer or something that's causing problems in the structure, then that's a what we call pathological problem. Functional is when the structure is normal or the tests are normal and is a problem of the actual is the function of the gut that's not working properly. Now the difference between that and disorders of the gut brain interaction, it doesn't tell you, the functional doesn't tell you what is the problem, whereas having the definition as a disorder of the gut brain interaction, that actually puts the brain as part of the problem. And I think it's important in looking at IBS that we need to be managing it more as a biopsychosocial model. We can go into it in a minute, but it's easier to understand the complexity of it when you break it down to that model. And it's easier then to understand the treatment for it, I think.
But in functional disorders generally, aren't they understood though as having a sort of, I mean, it's a kind of a central processing kind of error that's going on in terms of
I think we didn't know at the time what was driving a lot of the things, but I think there was a lot of thinking that yes, there was some other underlying problem driving all that. But yeah, I think having that new definition, I think it validates people's diagnosis, and it's easier to explain and easier to introduce therapies that target the brain because it comes with a lot of stigma. So I think it's important
all in your
from
mind
that.
side of, people feeling you're telling me it's all in my mind.
Yeah, and it's important that when we have that terminology now, it's easy to explain to people how these therapies can help and why this is the problem. So yeah, that is the I think the biggest thing that's changed, and I think giving people the validation that this is an actual disorder. It's not all in your head, but your head plays a part in it.
So great, and let's get into that in a minute. I want to understand also from your point of view of saying that obviously there were some indications even quite early on, and then we can talk about how the research has evolved, that hypnosis was good for these sorts of things, good for psychosomatic disorders. It's always had quite a strong reputation, not quite maybe mainstream reputation, but quite a kind of strong sidebar reputation as hypnosis in the hands of a medical or psychiatric professional as being good for psychosomatic disorders. Individual case studies and literature built up around that since sort of the 50s and 60s, I think, really. But is that how did you see that this was effective? When you were interested, had any randomized control trials been done? How did the research picture evolve in terms of hypnosis and IBS?
So it started in the 90s, mostly. So there's different groups that did different studies. So obviously has now 30 years of research behind it. So it started in the 90s with Prof. Warbur's work. There's also the North Carolina group with Prof. Paulson's work. And there's also I think it's from Scandinavia. There's another group, I think Simran Magnus Ingram, that does a lot of research through it. So there have been specific groups that have obviously had different protocols, and they did establish that obviously they were effective treatments. And now with 30 years of research, now we have meta-analysis that actually can tell us that the numbers needed to treat are very low, which is good, which I can go in a minute to say that. But we have significant amount of evidence that this is an effective, evidence-based technique that we can use.
Fantastic. About how many we can talk, but how many randomized controlled trials have been done roughly? Do you know?
I can't remember, but yeah, it's been a lot. Yeah.
And the meta-analyses are covering, yeah, they're looking across all of those there.
Hmm.
Okay, well, let's dive in and find out. We can come back and look at Hypno-CBT and how that whole journey worked for you there. But let's talk a little bit more about the the types of gut-brain axis, or if you want to call them functional disorders. I don't know if we're going to call them that. But what are the different types? Because you talked about inflammatory bowel disease. Obviously, we've got Crohn's and different things like this, and if those fit in or not. Maybe it might be helpful to people to have an idea broadly of the different categories, and then zoom in on IBS.
So inflammatory bowel disease is a structural problem because it
Oh, it
has
is.
a
Okay.
problem
Yeah.
within the structure. So it's inflammation driving the problem. The disorders of the gut-brain interaction, as we said, is the function. So there's nothing, the tests are normal. So each part of your gut can have a disorder of the gut-brain interaction, if that makes sense. So you can have problems with, well, we used to call it functional dyspepsia, or non-cardiac chest pain. You can have problems with your gallbladder that related to that. You can have problems with your so you can have different subtypes
Wow.
affecting different parts of your body. Yeah.
Okay. And then we've got and then IBS. So let's zoom in a little bit more on IBS and kind of the prevalence of it, perhaps,
Hmm.
and different levels of symptomology and severity. Because I don't think everyone's kind of aware of quite.
Hmm.
I know Olaf Paulson's like think it's massively prevalent anywhere. I think his prevalence numbers are huge. I think for IBS.
So IBS is very common. It affects 1 in 10 people, but obviously it affects people in different ways, and the severity of it is different. However, I think to understand the severity of the problem, because again, there's a lot of stigma. We minimize people that have IBS, that, oh, it's just a bowel disorder, like, um, it can be, let's look at the cost, because I think that people like statistics and they like understanding numbers. So it can cost the UK economy, based on the diagnosis and the health anxiety and all the investigations that happen, it can cost up to 4 billion a year. It can cause the going to the actual problem with the people suffering. So it can cause significant amount of absenteeism from work, and also loss of productivity at work. So it's been estimated from studies that it can be up to 2 days a week. I think the fact that people can work from home has helped, but I think now that people are forced to go back in the office, that's another issue that we don't take into account, that some people might have problems with that. And it's the emotional and social cost for the individual that suffers, because 60% of people avoid social events. It can cause intimacy problems. The quality of life is significantly affected, and it can be equivalent to someone that has chronic end-stage renal disease. So people that are on dialysis. So it's a very significant problem, and it can affect people in severe ways. And I think it's important that we don't minimize that.
So 1 in 10, sort of mild to moderate, and then severe is that what you said? Then severe is a subset of that.
No, no. 1 in 10 people will have IBS. The severity depends on the psychological burden and the
Mm.
stigma and other factors. So, and I think that's probably easier to explain with the biopsychosocial model in a way. So then we can go into it a little bit more, because there is evidence that's coming out about different clusters, and that we shouldn't really be, because at the moment the way we manage IBS is based on the symptoms. But I think what we're getting through studies and recent information is that the psychological burden is important to be taken into account, and then you can divide them into clusters, symptoms plus other things, and then you can personalize the treatment. So I think there's a lot of development that's happening, which is exciting.
Interesting. So do we want to let's dive in and talk about this kind of
So
biopsychosocial approach?
yeah, so if we break it down, so I'll try and simplify it. So obviously, because there's a lot of people that don't, we can use some terminology, but I'll simplify it a little bit more. So when we say the biopsychosocial, obviously there's the biological thing that's happening, the physiology that happens. We've got the psychology behind it, and then we've got the social aspect, which is some of the drivers that are happening, that stigma and other things. So with the biology or the physiology, what happens is it's a multifactorial problem. So it can start with gut, so the function of the gut. So you can have problems with how things are moving in the gut. You can have problems with the sensors within the gut, so they're oversensitive. You can have problems with the microbiome. You can have inflammation that might be driving things or recovering from the inflammation. And then you have the autonomic nervous system dysregulation, so it's constantly on overdrive. And then you have your brain, which is the central processing, the perception of things, and that it cannot downregulate, especially pain. So we do know biologically the gut and the brain develop from the same structure when we're an embryo, so they are connected from the beginning. And then as we grow and they grow into separate structures, they all have their own nervous system. So that's why the gut is called second brain, because it has its own nervous system, and they are connected with the autonomic nervous system as well. So they're constantly communicating. So anything that affects the gut can be interpreted from the brain as well. So, and this is where the processes in the gut and the fact that the brain cannot downregulate things, it creates this massive loop. So the way I explain it simply is I use a metaphor, which is the plumbing system connected to an alarm and the control station. So your plumbing system has its own sensors, which, if you think when you go to a supermarket and there's a car that the alarm is going off and nothing has touched the car, no one's in the car, and it's just going off, is what happens to your sensors. So anything that's normal, sometimes it can trigger them. And then it stimulates the alarm system, which is the autonomic system, which goes to the brain, the control system, which usually the control system can downregulate and say, this is a false alarm. This is not, we need to just stop this. This is not, but it doesn't. So it just then perpetuates the problem, and you can end up in this vicious circle of two organs speaking to each other constantly and shouting in a way that there is a problem.
And there is, within that, there is some organic change that's occurred at a sort of neuroplastic level, right? It's not measurable as in terms of, measuring, but something has changed in terms of the neurology or of the gut, what's being reported here and how it's getting reported there, etc., and the reactivity. So there is some neuroplastic changes that's occurred,
and they did, I think, some functional MRI testing that has shown that people with IBS do experience the pain is real. It's the way that is the brain is processing the pain that's it's not that they're imagining the pain, it's real for them.
And then another part of that is the muscular system, in terms of most of the gut is it's a lot of muscle, right? For moving things.
And this is the motility. So as we said, the way things are moving. So that's the biology of what happens. So that's even complex. The biology is complex, but then you've got your psychology, which, if we break it down to your risk factors, your precipitating factors and your maintaining factors. So with your psychology, your risk factors are your personality sometimes can play a role of how you see the world in a way, your previous experiences, some of the adverse life events that you had in the past, or how you develop some coping skills, you're avoiding things, or you're not avoiding things, your And some of the personality traits that we know, like perfectionism, can be related with IBS and maintain the problem in a way. And then we have the precipitating factors or the influences, which is stress or something significant, a life event that happens, or an infection. But that's obviously it upsets the biology mostly. And then we have the maintaining problem, which is the behaviors that we develop that actually maintain the problem, which is avoiding to go out, focusing on your symptoms, and having symptom anxiety. And some people just keep constantly going to the doctor because they want the reassurance that something's not right. They need investigations. And the other aspect is the food fears that people can develop. Like, I can't eat this because I have this. So yeah, it can affect people in different ways.
And then bowel checking and going to the loo 4 times before you leave the house. And
yeah, you develop rituals and you develop behaviors that for you think you're in control, but actually they're controlling you and maintaining the problem, if that makes sense. So that's the psychology. And the social aspect, obviously the stigma that's around it, and some of the lifestyle things that we do, like can affect your sleep, and sleep can affect your symptoms. So there's a lot of that as well happening.
so, and that aspect of social withdrawal, people not engaging so much socially,
Yes.
but then impact also on intimacy, you said as well.
Yeah.
So, and that sort of functional impact on people's lives, I think that's you know, an, we're always looking to see, what's the degree of functional impact of this thing that's reported. So, I mean, that's the kind of thing I think always a key area to look at. And
It has significant impact, the quality. And I think this is another part that we need to be assessing as part of the clusters, is the significant impact of the quality of life. Because obviously the higher your psychological burden, the higher the severity of your symptoms, because obviously that can affect your biology, as we said, and you can end up in this vicious circle that maintains a problem. The severity of it is higher.
I mean, I've had, more than a handful, but not lots of handfuls of IBS clients over the years. And what struck me many times is the social aspect. I had a young girl who came to see me, and we did all the gut focused hypnotherapy, did lots of CBT and and learning just to like tell her friends, hey, well, I've got to stop the taxi and I've just got to go behind a bush. And, but basically, how to cope with the catastrophes. And so they're not catastrophes anymore, decatastrophizing, planning and things like this. And she was quite a lot better by the end of it. But in her final session, she said, I think the reason is because of my best friend, or my so-called best friend. She said, since I began to be friends with this person, that's really when my problems started. And I realized, like, I'm never really myself with her, and that it's not she's slightly putting me down, but she is a bit. And it's been a very sort of, I don't want to say toxic, but it's not felt like it. Now I look at it, it's not a healthy relationship. And I feel the disturbances started since then. And I thought that was so insightful.
It is, and I think that highlights the stigma. So the stigma comes in different ways, and it comes like there's the medicalized stigma that we as doctors minimize a disorder, and people feel dismissed, which should not be happening. There is the societal stigma, which is exactly what you described, that people minimize other people's symptoms, and also bowel problems. We either, as a society or as a cultural thing, we see it either as a funny thing, a humorous thing that we make fun of someone that, you shit your pants or something like that, or we look at it as very embarrassing and dirty and something that people should be ashamed of. So that is on its own can have a significant impact of people's psychology. And then the other type of stigma is the internalized stigma. It's what the person feels. And I think a lot of the time, unfortunately, there's a lot of information out there and people get overwhelmed and they try to self-manage. And they end up in this frustration of doing lots of things that don't work, and they end up blaming themselves And then that problem, that frustration and the blaming themselves can create this internalized stigma, which then can lead to them avoiding to go and see the doctor, or having more severe symptoms because of this psychological effect that's happening on them.
Mm. Yeah, no, I can see the stigma thing is huge. I think she was particularly feeling that her sense of being kind of calm at ease and comfortable in her own skin had stopped when she met this friend, and she tried to kind of fit in. And in that fitting in, she kind of recognized that it's like she created this internal disturbance by not being herself. Does that make, I mean, that's when I was kind of
Yeah.
looking at that sort of, and I've had quite a few clients where they've actually really wanted to work on a cert. They haven't wanted to work directly on the bowel. They've actually realized, no, I need to work on this because this seems to be what's like, I mean, I always say it's kind of back to sort of some somatization of internalizing issues rather than expressing them. But I think there's an interesting aspect to that in terms of when we look at the social setting the person's in, and are they able to be at ease, free, expressive, or are they constantly guarded about their internal process, not just the fact they've got a bowel problem, but does that make,
Yeah.
I don't know if that's
Yeah,
something.
it is. And I think the emotional aspect, I think a lot of we don't address it a lot of the time. And there's, a lot of people are not in touch with their emotional. They keep everything down and they try not to be expressive, and they don't acknowledge what's going on within them. And I think that builds up eventually, and it can manifest with the stress building up and other things happening. It can manifest as bowel problems. I've got a client at the moment that presented obviously with IBS, but we didn't have to do a lot about it to improve. So we just did some relaxation things and all that. But then we're working now is more, we have highlighted that is the work related issues that are causing the problem. And yeah, as you say, assertiveness might be one, or it might be how you emotionally express yourself. And, so there's a lot of things that you can help people with, because it as I said, is biology can be one thing, but the psychology behind is a completely different aspect. And I think that's the beauty of it, that you can be a detective in a way and try and figure out.
And
And
figure out. And by
yeah,
psychology, we mean no, we don't just mean thoughts. We mean thoughts,
no,
feelings,
feelings,
and
emotion.
behavior. Yeah,
Yeah,
and
yeah,
behavior.
yeah, yeah, yeah.
I that line from Salter, they don't vomit forth nauseating emotional food. They try to digest it, and it makes them sick. And I think certainly with a subset of people I've worked with IBS, that's been a kind of certainly quite a strong pattern they've got.
And there's also like a personality trait, which it's common. It's called alexithymia. So it's from the Greek, so you can't express. So it's when you don't understand your emotions and you can't express them, and sometimes that is kind of is part of IBS as well, or is related with IBS. So yeah, so it's important that we see the whole person as a person and how they process things, and understand exactly where you can help, because yeah, there's the biology, but this is where we focus on, is the psychology. But also with the treatments that we have, the gut directed hypnotherapy can help significantly with the biology by the mechanisms and down regulating things. So yeah, it's fascinating.
Yeah, I sense you enjoy seeing all the different aspects and where to go with it. So that's the biopsychosocial is allows us to be really doing our assessment and information gathering and kind of working model conceptualization of the problem, and then the treatment plan from a kind of big sort of 360-degree view.
Mm-hmm.
Are there any particular, before we dive into looking at the effective treatments, are there any particular formal assessment tools that you use? Obviously, there are probably some that are kind of more in sort of mainstream medicine, but also on the psychosocial side as well.
There are types of questionnaires you can use, which you can use the visceral hypersensitivity. There's a questionnaire for that. I think it's important that whatever you use, I think it's important to understand the baseline. And I think breaking it down, obviously, because it is a complex problem, I think breaking down the psychology as, you know, if you have risk factors, obviously you can't change the risk factors. But if you have a precipitating factor, and then what is maintained, trying to understand what is maintaining the problem, yeah, and then that makes it easy. And there's another questionnaire, the IBSS questionnaire, which is the severity score, which is mostly about symptoms. So none of those have the psychology behind. I think the VSI questionnaire, which is the visceral hypersensitive one, does have about perceptions and the anxiety behind the symptoms. But regardless, I think you can sense it quite quickly about. So if you break it down, is, you know, the break it down in the psychological, but also the how is it affecting them in the quality of life. So which areas of their life is being affected? Is it social? Is it intimacy? Is it? So it's important that you touch upon a few aspects, so then you understand how bad the problem is.
And then would you go into taking, you know, where does this show up, and where does this issue particularly show up in your life? And do you then go in and do kind of a little sort of zoom in on those situations to try to get a picture of what's going on in terms of the situation, thoughts, feelings, behaviors, consequences? Or
it's hard because I think everyone's different, and sometimes obviously people don't want to volunteer a lot about, especially if you're doing the assessment firsthand, and you know they don't know you. So I think things do come out as you go along with a lot of people, and I think this is the part where, as a therapist, you have to be flexible and obviously use active listening and make sure that you understand what is going on and what they're trying to tell you, because sometimes, you know, they might come with one thing, but it's like the iceberg. You can see the tip of the iceberg, but you don't know what's happening underneath it. So I think it's having that thinking that, okay, what can I understand? Why is this happening? What's maintaining the problem? And keep making sure that each time you have an understanding about it. And it will, but as you go along, obviously sometimes things will come up, and yeah, you just have to be flexible in working with that.
but it sounds like, you know, so I mean, for everyone to understand here, you know, so predisposing factors, vulnerabilities or risk factors are things that kind of personality factors and previous life experiences that might lead you to develop IBS, or if we're talking insomnia. And then the precipitating factor I always get is somebody got basically food poisoning.
Infection.
Usually.
They got, it's very common.
6 weeks their gut's a mess, and then it never gets better. And that's the main, and that is understanding, and the maintaining factors. What is keeping the problem going? In terms of biopsychosocial, and bio would be kind of understanding, I'm guess, kind of that maybe the brain's kind of got into a bit of a pattern with the gut. We don't need to understand the actual neurology that's going on, but there's something, and then but we can zoom in on the psychosocial maintaining factors. Okay, and also this aspect of, but and what you were talking about there, and I think with also the stigma aspect. I mean, when people come to talk to particularly a private therapist who's working with IBS, there's clearly a chance for them to talk and be heard in a way that probably they might not have experienced before.
Yeah, that is correct. Yeah.
And this, I mean, and that can take, that's very important. That's a very important aspect, right? That they could suddenly a caring professional is here, really interested in their bowels and their poo, and they can talk about it totally in a relaxed way. But there might be might take time for them disclosed to feel comfortable. I think that's what you were saying earlier. Yes.
Yeah. And it's obviously, as a therapist, being non-judgmental, being an active listener, and making sure that you validate them, because it is horrible. I think a lot of people have been dismissed, so then the probably they have gone through a lot of different treatments that failed. So there's a lot of, oh, will this work for me? There's a lot of uncertainty, and, to build trust and be able to be vulnerable with someone that, you just met.
Yeah.
It's something that it takes a while for people to open up.
Yeah. And I think I mean, in terms of just that aspect about people feeling here's a caring professional and kind of the core conditions, so to speak. I mean, it seems like and feeling safe and at ease. And even, when my sessions, we've even ended up having quite a laugh about things. And suddenly, because, it's safe to do that, to talk about and then what might have happened, what nearly happened. But I think that could be like a huge part of this anyway. And I'm sure some studies have been done where we've compared just really good supportive listening from an understanding professional compared to using, an intervention like gut focused hypnotherapy. I haven't looked at the literature on that, but I've got to feel that just that aspect, the supportive aspect, has got to be a big
Yes.
factor.
I think there's been so Drossman, who was a big, I think he's retired now. He was a big part of their own foundation. He has developed, he has done a lot of research around it, and I think how you approach the functional disorders, the communication skills of the health professionals is very, very important. But yeah, the important points is obviously not judgmental, validate them. And just be active listener, making sure that they're being heard, and providing the right support. It's is what's really important for them, and providing like this is a safe space for them to say anything, because it there's a lot of other things that happen with IBS that people might not want to disclose. So.
And therefore, and we talked, so, the assessment, the information gathering is ongoing, and things like doing a specific situational analysis. Let's kind of zoom in and see what actually went on just before, during, and after that. What were your thoughts, feelings, behaviors, to try and I'm assuming that's the sort of thing I would do, but that might come later. You're saying as part of the ongoing kind of building up
I
the
think
picture.
you need to have an open mind and making sure that each time you I always start with obviously reviewing the previous week, what went well, what didn't went well, especially if we did like a behavioral experiment of some sort, get the information, and then I can understand why something didn't go well and how I can help. So you have to be a little bit flexible as well in what you hear as well, and adjust, and making sure that you motivate people instead of, oh, that didn't work.
Yeah. Well, we can talk about motivation, because I think that's going to be very, a very important aspect of this. But so let's look now at sort of the effective treatments broadly, that are out there, and any sort of myth busting as well, because people can get into stuff that there's a lot of stuff out there about different things and what's going on in your gut, and maybe because you've got an allergic response to lots of foods, and there's the York test and all sorts of stuff out there. So I mean, there's a whole mix of actually really evidence-based interventions here, some unexpected like gut-focused hypnotherapy, and then we've got a whole bunch of nutrition and dietary and supplements and all sorts of stuff going on that's, it might not
So
just be not effective, but might actually be problematic, right?
So yeah, let's break down what works first. So we do know, the way I explain to people the IBS management is like the three pillars that you have. So one is the medical, where you focus on symptoms, or if there's significant anxiety, that you need to give someone medication because it can be significant. Sometimes the anxiety needs to be treated first.
Depression as
So
well, or not? I mean, because depression can be quite a big factor as well, can't it?
it can be, yeah. So yeah, it is important that, again, when you assess people, that you make sure that they're not severely depressed, that they require further assessment. So there's obviously, you have to make sure that your selection is the right person that you take on. So the medical treatment and also target some of the symptoms. So there's different medications that you can use. So that's the medical aspect. So I'm not going to go into details about that. And then you've got the dietary aspect, where the proven therapies, dietary therapies for IBS, and I think this is again an evolving area, and I think a lot of things are coming now into play, is the low FODMAP diet, which has 20 years of research behind it. And what is a low FODMAP diet is basically, the way I describe it is a dietary intervention, which is a dietary intervention is basically something that needs to be supervised. It's not someone to do it on their own. It's a very complicated diet, and it can lead to severe restriction. And unfortunately, what happens, because we don't have, because of the waiting list and because of all the problems that we have at the moment with the system, what happens is a lot of people are told, just go and look it up. And they end up severely restricting things unsupported. And then they can end up with losing weight and developing restrictive diet behaviors, which can end up leading to food fears and other stuff. So the low FODMAP diet is a great diet, and the numbers needed to treat for that is 3 to 4. So the number needed to treat. Yeah, I'm going to say. So from the meta-analysis, obviously, when you've got a lot of data, what they do, they pull the data and then they give you this number, which is basically, it's for one person to benefit, you need to treat 3 or 4, which is a very good number. Because some medications might be 8. So for one person to benefit, you need to treat 8. The evidence.
I think when people hear these numbers, people don't understand actually the numbers needed to treat, that they are quite high sometimes. But people would think, well, if it's an effective medicine, surely the number needed to treat is 1.
Well, yes. But and so for the low FODMAP diet is that, but as I say, the important thing for the low FODMAP diet is that it should be supervised, and it's not for everyone, because if someone has already restricted down and they have food fears already, restricting more is not the way to go. There are some developments that are coming through about the Mediterranean diet that might be of benefit. There is the low carbohydrate diet, and there's other diets that there's evidence coming through, but we don't have a clear information yet to say this is exactly what you need to do. And I think, again, personalizing things again is going to be part of the diet aspect. And then we have, so we've done.
Do you mean personalizing the diet, or saying, a dietary approach probably isn't recommended because of some of the psychological factors that are operating here? Because I remember watching Peter Wall. I've got that clip that we use in the course, where he's being, I can't remember who's goes up to see him, and they're having some food at their canteen, and he goes, he's ordering some chips and plate of chips or something, and something, she goes, is that okay? She says, oh yeah, you have to avoid healthy foods. If people are on a diet of healthy foods, gotcha, that's the problem. So I always remember that and I go, well, that fits in with the whole food fears understanding. But then we got low FODMAP and these other diets coming in. So
yeah, it's both, and I think, again, that's where obviously I'm not a dietitian, so obviously that's, and I think the important aspect of IBS is that there is a model where we should be following, which is the multidisciplinary model, where you put all the disciplines together. And we know from an Australian study that is a very cost-effective way of managing it. However, as I said, what happens is people get fragmented care, and obviously a lot of the psychological therapies, which is what we do, is not available in the NHS. And so people have to like, pay for it, or they have to go elsewhere, or they have to wait years to get the treatment. So yeah, in terms of diet, I don't want to say too much, because obviously it's a complicated issue, and I'm not a dietitian, but there are the basic dietary advice that we give depends on the type of fiber you eat, and there's a few basic things that you can give as a doctor, which is basically avoiding caffeine, carbonated drinks, fatty foods, and depending on what fiber you take, depending on your symptoms, because some of it can exacerbate things. And then we go into the psychological therapies.
Do you give any guidance on what to eat, what not to eat, or in
I
terms, or you steer
so
clear of that and just tackle food fears and
so that the people that come to me usually have failed the diet, and I think this is where um uh we have to have an open mind, because obviously the dietary aspect might not is not just the diet. So I think a lot of people focus on this is the diet, it's going to fix me, but as we've explained, is not just the diet. So I think people need to understand that I try not to give diet advice, because people can get quite obsessive about it, and it can end up in more problems. And usually the people that have come through me is through a dietitian, or so they've already tried something and it's failed. So I'm not going to take them back to the diet again, because it's not just the diet. So
Okay.
I focus more on the psychological aspect, which is the CBT, the hypnotherapy, and some mindfulness. And the number needed to treat for those. So the CBT is between 3 and 4. So for one benefit, you can, which is great. For hypnotherapy is 2 to 3. And mindfulness, I'm not sure there's data out, so I need to look that up. But so you can see how effective the therapies are. But I think you have to have the right patient selection as well to make sure that they are motivated, engaged, and ready to keep going, basically.
You mean, just give me, people who kind of more like give me a pill and fix me, or, they're not willing to do, I don't want
Yeah,
to say the psychological work, but there is an aspect of that, right?
yeah. I think the reason why people end up failing and going through all these things is because they want a quick fix. And unfortunately, there's not a quick fix, as we explained. Is a complicated problem, and it's not just one thing causing the problem. So if we have a multidisciplinary approach, is great. If we can't, then people end up going from one thing to the other, to the other, to the other. And I think by the time they get in their heads that I have to do this, you can imagine that already they have gone through a lot of disappointment and a lot of anger, frustration. So you have to make sure that you keep them motivated, because it's a long process.
And the
Not a long
nurturing.
process. It is you can have fast results, but it does require the engagement and then being open to it. So yeah.
And this nurturing of hope, very, very important. And this aspect of how can we work out where we might get the quick win. I've seen some clients where we get some wins much more quickly, and others, particularly who are more sort of have nearly a kind of worry disorder, kind of generalized
Yes,
anxiety disorder nearly, and they do not respond so quickly. Their
they
thinking and behaviors are much more ingrained.
they might need medication for that. So this is where you need to keep constantly adjusting and readjusting and assessing, is that some of them are not appropriate for the therapies, and you will find out who it is and who's not. And it's having that flexibility of making sure that you can adjust, and if it's not working, know that you need to refer back and make sure that they get the right support.
I mean, the great thing with the psychosocial approaches, and I'm going to call them psychosocial, not just psychological. Let's keep it, is that essentially, apart from the fact that it might not have worked in terms of the degree of symptom improvement, there shouldn't be really any real risk, and there probably are going to be some actual benefits that come from doing that in terms of learning to relax, learning to self-regulate. The, the As opposed to, for example, going down the dietary approach, there can be problems with that, as you said. I mean, so if we look at the iatrogenic, the likelihood of harm from the therapy approach, medication, well, we could talk about that. Dietary, there are possibilities of harm because people can get more fears. But in terms of psychosocial approaches, we're not really seeing that. It's just maybe opportunity cost, in terms of they tried that and it didn't work. But there
Mm,
should be some pickup of something useful in that in terms of quality of life,
definitely.
acceptance. Yeah.
And I think with also the psychological approaches, as I said, it's teaching people skills that they can take for life.
Mm.
And it's about building their self-efficacy and their resilience. And a lot of it comes with, just education and making sure that you explain things properly and then they understand it. And it's so transformative by just doing a little bit of relaxation, how it can help some people. And it's something that they can take onwards and use it every day. And it's very transformative.
Okay, great. I want to get into talking about how you work in a second, but let's scoot through these different things. We've got the effective treatments there. We've got medication, diet, and we've got then the psychological, psychosocial interventions. So, should we go through those? Just gut-focused hypnotherapy, particularly, and perhaps versus then CBT, because those are the two main sort of psychological, psychosocial interventions. Yeah.
Yeah, sure. So going back to the biology that we talked, obviously the patterns of the multifactorial aspect of IBS. So we've said there's the visceral hypersensitivity, there's the problem with motility, how things are moving, there's problem with the microbiome, there's problems with the dysregulation of the autonomic nervous system, and there's processes in the brain that are not down-regulating. So
let's just unpack a couple of those for people. The visceral hypersensitivity. I think probably about half the people here probably got that, and others might not get that. So should we just explain what that is? I think it's really key, isn't it?
It's like it's as like when you go to the supermarket and there's a false alarm, like there's a car alarm that goes off and no one's around and nothing's touched the car, but it's just the car alarm went off. This is what happens sometimes in your gut. So a normal sensation might trigger something because your sensors are very sensitive.
And they've done measures on this, haven't they? They put balloons up into people's guts and inflate them, and people who've got IBS can really sense it, and other people are like,
the normal sensations people have sometimes it in people with IBS it just people feel it so much and it creates stress and the whole cycle. So that's the hypersensitivity. We said the motility, the how things are moving. What else did you want to unpack?
I can't remember. I mean, essentially, I think the sort of the up regulation, down regulation, the kind of the dysregulation that's happening there. Perhaps just to explain that a little bit.
So the dysregulation usually what happens with the autonomic nervous system is so out of our control. Usually what happens is you get a stress and then you've got a fight or flight or rest and digest systems. So usually what happens under a little bit of stress, you get the fight or flight, but then it's balanced out by the rest and digest and you get back to normal. What happens in IBS or in these chronic disorders is that you have the symptoms that have triggered the fight or flight situation, but you cannot regulate. The rest and digest doesn't go in because of this cycle that happens, and because you think that the symptoms are causing problem. But also, what happens is that because of the fight or flight, the blood system is diverted from the gut, or it can increase the motility in the gut, so then you get more symptoms. So then that can play into that back again and say something is still going on, and then you can be in this chronic fight or flight situation because of the symptoms and how you interpret the symptoms.
So and just sorry, I like to get technical here. So with that, I mean, you're saying basically that there's a constant then like kind of mini fight or flight that's going on.
Yeah.
Or are you saying just the kind of the down regulation just is not working well either? So, because those are two different, both. Huh. Okay.
Both.
Okay. Because I'm thinking of some of the stress studies for people where they like a really loud noise goes off and then they measure how quickly the heart rate comes back down. they're not
Yeah.
having those intervening stressors. It's just that with people who have this dysregulated system, it takes a lot longer to return to normal, to baseline.
Yeah. Both. Yeah. So,
Okay.
and also the brain, because it goes to the brain as well. The brain then, usually the brain can say, this is nothing serious, don't worry about it. But then the brain cannot tell that this is not this is not a proper alarm going off. Then that plays into that as well, because it usually will not downregulate the signal, so it will just perpetuate it. So
Perpetuates. Okay.
yeah, so that's a problem. So yeah, so based on the physiology, the gut-directed hypnotherapy, we know that it helps with normalizing the visceral hypersensitivity, that it helps with the motility, how things are moving. We know that it helps with the regulating the autonomic nervous system. And we do know that in people that have pain, it can help with the pain processing and down regulation from that. So it has a multi-level effect. The CBT.
Go on. I was going to say, so let's describe what's involved in that, because I think the protocols, although they differ, they're fairly simple from what I can see in terms of the sort of, and they're quite standardized scripts as well that are given. So can we talk about actually what gut focused hypnotherapy looks like, and then what are the sort of
Yeah.
suggestions and how often people listen to them, etc.
So there are two protocols. One is the North Carolina and the other one's the Manchester protocol. And they are different in some ways in the fact that the protocols have been developed for research and making sure that whoever follows the protocol has an effect. So they can be quite prolonged in the description. And especially the first few ones, because obviously if you're just doing gut directed hypnotherapy, you need to make sure that people can relax, that they can, have the be hypnotized. But what the suggestions are about you being in control of your symptoms, how you can change the perception that you have on your symptoms, so you start not noticing your symptoms, and also the severity of your symptoms. You start not noticing that is that painful, or you replace it with a different feeling or sensation. So that's roughly what they do.
And then imagery, but imagery and hand on the gut and things like this, because
Yeah, you
both of them
can.
seem to be
Yeah,
quite into imagery, don't they?
yeah, yeah. I usually personalize it even more for my patients, so I don't follow the exact protocols. And this is what I like doing, is because I can do like we did the script exercise. Like I like using their language. I like using what they understand as the problem is, and then use metaphors that help them in a way and target their symptoms. So I do it a little bit different. And I think that might be where it's why I like the personalization, is that I can really hone in what the problem is
Yeah.
and help with
So, but
that.
I
And
mean,
also,
some of the standard, just to, so the standard stuff that's in your gut's a bit like a river. That's one of
yeah,
the standard sort of images, metaphors, and that you can control the flow of
yeah,
it. And it goes back to, and then I don't know what the North Carolina sort of imagery is, but they have, I don't know whether they have waves as an ocean or a lake, I can't remember. But there's some imagery that's
yeah,
kind of quite metaphorical in terms of the sense of the gut returning back to normal, calm,
yeah,
smooth. Am I
yeah,
correct? Yeah.
yeah, 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 yeah.
Um,
I can't remember the imagery on the North Carolina. I have to say that.
yeah, it's hard to get his scripts because he won't give them to anyone. You can probably get them, and he won't give them to me. But
I
anyway,
do have them, but I don't. Yeah, I'm not allowed to. I think they're copyrighted, so I'm not allowed to give information out on that.
he's Olive Palson's very restrictive. Not, I don't know about his diet, but he's very restrictive on his protocol sharing. Um, so, okay. So I think just for people to understand. So, and then people are coming in, they're seeing in a standard sort of protocol, they're seeing somebody half hour every week for 12 weeks and listening to recording every day. What does it look like?
I think from the studies is between 10 to 12 sessions. I think is an hour session. I'm not sure whether there's a full hour of hypnotherapy.
Mm,
Sounds like a lot. And they do, I think after this third session, they get a recording. I think according to the North Carolina protocol. Um, I'm not sure about the Manchester protocol when I think they get the recording early on. And so you
mm.
see them weekly or every few weeks. But yeah, I don't follow 100% of the protocols. I personalize my treatment
Yeah, and
myself.
I want to get into that. I just kind of trying to understand broadly. And usually people have to kind of say they got to listen to it. Was it 5 times a week at least or something? They're given, and it's pretty.
Yeah,
It's
it's
essential.
intense. Yeah.
It's like the central kind of part is you. This is
Mhm.
what makes it work. Is you do this
Yeah, yeah.
every day, basically.
And I think there is obviously the digital apps now. So there's Nerva,
Yeah.
which has a 6-week protocol, I think. So I think there's 6 different types, but there are some repetitive things. And it's it's 6 weeks, I think, that you have to do, I think, from memory. Yeah, I haven't used it or referred anyone, obviously, because I
And
was doing myself. But
do you know on the digital apps, do you know if there's been any studies done on those and numbers needed to treat? Because I imagine they're not going to be quite as effective as the personalized.
there are data coming out, especially there's been, so for CBT, there's not a digital app that's available. I think there used to be one in the US, and I think there might be some in development in the US. But there was a study for CBT that was done in the UK that checked that they looked at web, so online therapy, telephone therapy, and normal treatment. And it did found that it was equivalent, that you could have online therapy and it was fine. In terms of the digital apps, so there are some data coming out that they are effective. The problem, I think, and I think they're great because they can access a lot of people, and
Mm,
you can do it at your own home, at your convenience. However, the motivation is a problem. A lot of people drop off, as with everything that you do. If you don't have the accountability, I think, or the right support, you're just not motivated to do it. And some of them think that the cost is significant. Um, but yeah, there are some data out on the
what do you
digital
mean?
apps.
Cost is that people if people pay more, they're more motivated? You mean that aspect? Or what?
No, some people don't want to pay. Don't want to
Oh,
pay.
they don't
That's
want
it.
to pay. That's
Yeah,
interesting, isn't it? Something that's having
yeah,
quite a significant impact on their life, but
yeah,
yeah, yeah. I mean, I think it's a challenge in the public healthcare system because people are expecting it, and yet some of these things are going to require effort, even if they get involved, and it's not just let's operate on you. Here you are, you're better. And
yeah.
so, by the way, do they do any operation? I mean, I think we had somebody in the course, and her gastroenterologist was wanting to operate on her bowel because it was so like misbehaving.
Uh,
Is that still
Um,
some? Is that something that's done or not?
I don't think you do it for IBS. You can have sometimes you can have problems with evacuation. So you may have prolapse or other things happening that might require treatment, surgical treatment, but very rarely they'll do it for IBS. It must be something significant, or yeah.
And I had a client he was a little bit older, had a vagotomy. He'd had his vagus nerve cut, to his bowel. Do you remember?
That's old. That's
That's
very
very
old.
old.
Yeah, that used to be done for ulcers, I think,
Yeah, yeah.
bleeding ulcers if they couldn't control things. But yeah, it's very old, very old,
Very
very
old.
old.
So no surgical interventions. Okay.
No,
So and then just broadly CBT compared to the gut focused hypnotherapy, how does that look? I mean, the numbers needed to treat seem higher than for the gut focused hypnotherapy. And how does
it's only one person difference. It's not that deep. But the so yeah, so we said with the biology how the gut directed hypnotherapy works. For CBT is mostly about the down regulating the autonomic nervous system by teaching relaxation, and
oh, okay.
also and
Interesting.
also using more about the cognitive aspect, so they're targeting the catastrophizing, the behavioral aspect. So it's cognitive behavior therapy is different than targets different things than gut directed hypnotherapy.
It's interesting because in a lot of CBT, relaxation is kind of, oh, they're all like, oh, it's all a safety-seeking behavior, and they don't want to teach any relaxation. And lots of kind of areas of CBT kind of got into that. Whereas, of course, we know that it's been a big part of early CBT. Mike and Bam call it the aspirin of therapy. So, so in the CBT protocol, the relaxation training skills are quite a big component.
Yes. Yeah.
Okay. And is that a particular type of relaxation training, like progressive muscle relaxation? Is it kind of
Your breathing, I think breathing, and I
so
usually use diaphragmatic breathing, and so you can use the different types of breathing. Um, then it's tension release, yeah, relaxation, imagery sometimes can
imagery?
help,
Okay.
guided medit sort of, yeah. Yeah, I think these are the three types of
And
relaxation we can.
and has anyone done a sort of dismantling study or measured, for example, progressive muscle relaxation on its own? Because I mean, I of course I read Jacobson's original work, and it's like
Mm.
he's doing lots of stuff focused on the gut and X-rays of the gut and showing the changes before and after, because tension on the outside, tension on the inside.
I remember the photo you showed me. That relaxation. No, I'm not aware of that. I'm not.
Okay,
But probably are.
okay, because it's quite. I remember talking to Professor Peter Warwell about it, and he goes, "But it's really hypnosis, isn't it? Progressive muscle relaxation." I said, not quite, Peter, but that relaxation component being so the regularity of the depth of relaxation is kind of in all of those. It seems to be then a main theme. Yeah.
Yeah, and I think it's a difficult process. Relaxation is an active process, and I think people, when people say just relax, it's like it's not. It's just you have to make the effort to relax. So it's a bit of a paradox in a way. So I think, yeah, teaching people skills that they can bring into the stressful situations, then yeah, that's part of the CBT. I think it's mostly
And
skills training.
okay, so and of course these some of these things have a lot of spin-offs into the rest of their lives in different ways as they
Mm.
learn to stay more relaxed and can relax in situations. So let's talk about putting this together into the Hypno-CBT, because you were when we talked before, you were like, it's really cool to actually be able to bring these two things together, and then also bring this sort of personalized or tailored approach. So
Hmm.
how are you bringing you've talked a little bit already about that, but let's go in more depth about this.
So it's hard to I'll probably have to give examples because obviously it's hard
Yeah.
to yeah. So let's say um I had a client that was we had a problem that it was mostly the traveling the issue, and obviously they couldn't understand, and it was a long distance relationship they had, so obviously the traveling was a stressful part, but then when they were with their partner they were suffering symptoms, and then that played part into that. So obviously we broke it down, and because this person has had mindfulness experience before, and he was aware of techniques, it was easier to use mindfulness as with hypnosis as part of an exposure therapy, if that makes sense. So we would get him imagine being on the plane or something, and then focusing on the breathing and teaching that the techniques that he used for mindfulness, and that actually worked, and it was great. So I think being able to use two different techniques, because a lot of the time that with the the flying and the plane situation, you can't do something with them at the time. You either have to do a behavioral experiment where you teach them how to do it and then they go and do it and then they come back, and or you can use hypnosis where you can practice the actual
run a simulation really of
exactly
the situation, and
exactly
and so they're able to kind of nearly trigger their response and then down regulate it and cope with it.
And another example was I had someone who's close to retirement, so he was really bothered with not being able to go out because he had what we call toilet anxiety. So he was stressed about, whereas always scanning for toilets. So, and he wouldn't even take his dog out for a walk in the woods because obviously it's like, well, what do I do? So we worked slowly with relaxation. So we had a good effect to start with, but then it came up that his daughter's wedding was coming up and he was going to walk her down the aisle. So we did specifically practice things that were gonna, and actually it worked 100%, and he was fine, and there was no issue from that. So, and this is why I love personalizing, is because you get a glimpse of what people's struggles are, you can help them, and then it's just transformative. And I think it's such a, I don't know, I love it.
So in these cases, very targeted rehearsal in hypnosis, simulation of the actual situations that are causing are really the focus of the concern.
With the skills that they've learned as well.
With the skills they've learned as well. Okay. I can see that. I mean, I think of some of the cases I work with, we did quite a lot of decatastrophizing in terms of problem solving. So, if you lose control of your bowels in the middle of Oxford Street, what are you going to do? Let's come up. Plan A, you don't. Plan B, okay, you do. So what are you going to do? So which would seem a bit hardcore, but actually it calmed them down once they realized they could jump on a taxi and give the person up 200 quid. I mean, he had some money, so he could go in a shop and just, but basically just rehearsing that actually there was a way of, it's not the end of the world.
Yeah.
Or
I don't like decatastrophizing using it from the beginning because it is quite and having to go through the college training where someone had to do it on me, I was just like, oh my god, this is horrible. So from that experience, I find it like a little bit difficult to use it straight away, but yeah, it is effective.
It's hardcore, but I find like suddenly then that's like the stress is off. They've got a plan B, and it's like, so what? That's what I want to get to, and
it will peak to a point where they're just so stressed, and then it just like it calms down, and you're like, okay. But that part where they, it's not very, very nice to see, I think.
Well, there's been a lot of discussion of like what were the kind of problem solving it though. It's like they're like, it can't be faced. Well, if it happens, let's discuss what would be some of the things we could do. By having a plan, they no longer are so they're not so stressed about it. So yeah, I ended up doing a lot of decatastrophizing with my clients. But then when I talked to Peter Warwell about it, he said, well, my clients, it's not just a potential thing, that's never going to happen, that they need. It happens. They lose control of their bowel all the time. That's really severe versions. So yeah, he wasn't so keen on my decatastrophizing. So I mean so we've got decatastrophizing, what going rehearsing in specific situations, but then also the general protocol of relaxation, self-efficacy, and so let's can we talk through some of that aspects and then how you tailor that? And you mentioned about tailoring imagery. Could you give examples as well of?
So I usually use the safe place as a something that I build on. So and it's like a lot of the time is people like the beach, so you can make it really descriptive, and then you can incorporate other imagery. You can put like the white light if you want, or you can use the hand warming as well and build on that. With self-efficacy, what I like to do, obviously, depending on, again, obviously, as you go along, you'll find more about them, and when they trust you, they'll tell you more things. Is, confidence is one of those things that I think a lot of people struggle with, and building on that, or understanding what confidence means to them and using that maybe as an imagery, like, how you can project yourself in that sort of image of confidence. What
So,
else?
so you're talking kind of social confidence here, not confidence over my bowel, but
No, I mean, it can't, depends. It depends on what sort of confidence issues they have,
Hmm.
and you can always really personalize it to them, I think. And it's, yeah, this is good because like you can grasp an idea of how someone wants to behave as well. So you can put that in, there's a lot of things that you can do, and it's just being flexible and making sure that you listen to them and really target things properly.
So how do you, yeah, I mean, that's an interesting aspect of about, how you're tailoring it in terms of, um, in this case, you're leading over to sort of suggestions and imagery of social confidence in general as being a component that is going to make a difference with their IBS, which is interesting. How do you come to like zoom in on that as a particular?
I don't always do it. I'll do it if I had on my assessment I could find that there was an issue, let's say, with being at work and not being confident because of ABC or something. So put it through that way. I don't always put it in. It's not what I always do. This is what it's hard because I can't give you all the things that I do, because obviously it is depends on
Yeah, yeah.
individuals, and every individual is different, and this is why you have to be a detective and
But
find
you're
out.
so you're
And
saying that this is what's maintaining stress levels, this is what's triggering,
yeah,
looking at
yeah.
what might be maintaining and then what might be triggering as well, and then coming in and targeting those there. Um, interesting. Do you use a pendulum at all as a
No,
as a? I mean, I thought that's always an interesting in terms of mind and body, mind controlling body, and that sort of aspect. Because that, how then the aspect of self-efficacy in terms of self-hypnosis or self-regulation, because this seems to be a very important part of sort of them, that sense of like, oh, I have some agency in this situation.
I don't understand the
Or just
question.
a kind of
Sorry.
how do you bring that in, the self-efficacy part? I mean, you talked about social, but
Yeah.
much more broadly, this sense of you having some control.
So self-efficacy obviously comes from the confidence in managing your symptoms and coping with challenges. So I think the self-efficacy comes from giving people skills. So I think it's more of the CBT aspect
Mm,
that helps with that. So potentially you can use some of the CBT like exposure things again in hypnosis. But it's hard because obviously, as I say, it's difficult to know what works for one person, what it might not work for another person. So it's not something that has a clear protocol for me, if that makes sense.
yeah, so it seems like it's quite an informed but intuitive, and then also let's see what works process of the treatment. Am I right with that?
Yeah, and always you reassess each time and see what worked, what hasn't worked, why hasn't. Yeah, and you just keep going and making sure that you adjust. And if something doesn't work, let's do something else. It's not.
Try something else out. Okay, let's have a look at a few of the questions here. Now, someone's just put in here, Sarah, which I love this. She's put in, I'm struggling with the idea of control. Isn't letting go of control the key to symptom relief in many cases?
Yes, yes. Acceptance is, yeah, I've seen that if people say
Mm.
acceptance is so part of building resilience. I think there's a few steps in resilience. I think acceptance is number one. And we're not saying that acceptance is that, oh, I've got IBS. It's about, I have IBS, but I can do it's not taking people's identity, because I think you can end
Mm.
up having this learned uh, helplessness. Yeah, learned helplessness. That can be part of the problem. So yeah, acceptance is important. I think having optimistic outlook is important as well. And the fact that yes, I have IBS, but I can't do ABC. You know. Um, Also, the right support system, as you mentioned earlier, is important, because I, if you don't have the right support, and you need to know who it is that you can turn for support. I think that's part of your resilience. Yeah, so I think teaching people skills and accepting things is part of the process as well.
But I think if we zoom into acceptance, we're saying, rather than like struggling with the symptoms and going, oh, and feeling attacked by the symptoms, there's a kind of an acceptance and a kind of we're practicing a non-reactance to the symptoms. And then
Mm,
the other thing you mentioned, optimism. The other thing I think to cue into that is a curiosity rather than
yes.
a sort of an acceptance and curiosity, and then an optimism in terms of like this isn't necessarily going to stay. This isn't this isn't the end of my, so
Yeah.
and let's then see. But there is, this aspect of agency versus control. It's interesting, so eh, agency comes in once we start to accept, then we can begin to change.
Control can be difficult though, because there has to be, in order for people to drop their control system, I think there has to be trust, and I think eventually you'll get there. It's just like the control aspect. I think you can use it in hypnosis, and that you're more in control of the symptoms, but also at the same time is it will eventually come towards, as you go through the process of assessing, getting the information, trying things out. It's very difficult to have straight into it that, you know, targeting the control aspect from my perspective. I don't know what you think, but
Well, I think I'm going to come back to Bandura on this and really understand. He broke down the steps of self-efficacy, or in his book, the exercise of self-control, and the first step of self-regulation. So his
mm,
ability to self-regulate and to bring down and to change emotions, affect, yeah, and to relax the muscles. And of course, to relax the muscles, it does mean letting go, but it is something you can do. So it's
but
or something you
I'm
can stop
gonna
doing.
I'm gonna take another step before that, is the
Yeah,
awareness, that you
mm,
need to
yeah,
be aware of what's going on first
yeah,
and
yeah, yeah, yeah.
understand it before you start accepting and being less responsive. So yeah, it's a process.
Awareness. And that then that I can there's some self-regulation that can occur in terms of relaxation, emotion,
Hmm.
attention, all the
Hmm.
aspects of basic self-regulation. Um, that this is the first rung on the exercise of self-control. I actually can self-regulate, I can relax, and I can focus
Mm.
my attention. And I
Hmm.
think that's making sure that is in place. People realize I can relax and I can point my attention here, rather than I can't relax and I'm just dragged around by everything that's going on around me or inside me.
Yeah.
So I think that sense of that control is important. And we could also talk about, I mean, this aspect, I like to talk about the spotlight of attention. And of course, when you look at what's going on with people with IBS, is they are spotlighting what's going on in their gut, this visceral
Hmm.
hypersensitivity,
Hmm.
and they are aware of that. And the first thing they do, I like to think what when people wake up, what's the first thing they do, because that kind of and of course people in insomniacs go, oh, did I sleep enough? How's my sleep? Will I cope with the day ahead? And people with IBS go, oh, how's my gut feel? What's my day going to be like? The first thing they do is check their gut. And so then showing that they can actually change that, and that's not the most salient thing in their life. I'm thinking about
Mm.
salience networks in the brain, and like that's not the most important thing to focus on. Actually, that's the problem, is that,
It's the same with health anxiety, not just IBS. People that have health
yeah,
anxiety, they just focus so much on their symptoms, with the attention goes there. Whereas if you start training your attention into, you know, being aware where your attention's going, and then teaching yourself to put your attention somewhere else, then that becomes a process where you can help things. But yeah, it's not just for IBS. I think it's for anything that creates health anxiety, or any chronic problem, I think, that can create this problem.
so I mean, would you see certain types of IBS as falling within health anxiety? Would you see a lot of IBS as falling within a category of health anxiety, perhaps?
Well, I think the symptom vigilance is a part of IBS, and yes, there is part of that. But I think health anxiety comes with other disorders as well, so it's not just
Yeah, yeah.
specific for IBS.
And there are
So,
specific patterns that are going to go on with IBS in terms of the visceral hypersensitivity and all of
and
that.
and
And
I think and I
yeah,
think the important aspect that we're talking about is not like the biopsychosocial model you can apply to a lot of other chronic illnesses that, let's say maybe fibromyalgia could be one of them.
yeah,
It's
yeah.
there's a lot there's a And I think when you break it down that way, I think it's easier for people to understand and why it's happening and how they can help.
Yeah. So I'm guessing, yeah. So there's some strong ideas and formulations one can bring in from health anxiety that could inform, but they don't really doesn't paint the whole picture of what's going
Mm,
on with IBS,
mm,
but
yeah.
could provide. And again, with some clients, that kind of model and understanding that aspect could be
Mm,
the most effective and powerful intervention component. And I think it also is going to change through the course of treatment as well, which
mm,
how do you decide where to start? Because I think this is always, to me, it's always like, when can we get a big easy win? Where could we, with this client, do we need to, is it acceptance? Is it self-hypnosis? Is that relaxation? I mean, is that how what's your process in terms of a tailored treatment
I
plan?
I start by understanding what. So first of all, I think having realistic goals with them, exactly understanding what their expectations are and putting a
Mhm.
very realistic goal that you can reach. Because having unrealistic goals is, you're gonna fail. Like you're not gonna get the engagement, and you're not gonna be able to deliver a result that is
Okay.
effective for them. So I think having a realistic goal, and then the way I approach it is, first of all, I do the education and I make them realize the awareness, like go through the biopsychosocial model and explain more about the physiology of what happens. So then they understand that the symptoms and the psychology play into it. And then it depends, because I do like doing understanding the triggers as well. So I do give them the thoughts, emotions, and actions, like a form that they can fill in, so
Mm.
they can understand their pattern themselves. Because I think once you're aware of what you're doing, it's easier then to say, okay, so you're doing this at this point, we can do this, and then teach techniques, relaxation. And then I don't start with hypnosis. I build the hypnosis into it, because I find sometimes it's hard to explain it and make people engage in it very early on, I think. I don't know. What do you do?
Well, I'm always concerned that people are coming to me for hypnosis for like they want me to do the magic, just put me
Yeah.
under, fix my bowel. And so I'm like, so I'm a little bit, and if I sense that, then that's the last thing I'm going to do with them because they got to, we're going to go this. But generally, my approach is tension release. That's where I'm going to start because I know it's easy to teach. It's got wide application throughout their lives.
Mm,
I'm making the biggest change I can possibly in their nervous system, which is, down regulating the amount of tension signals going from the brain into the skeletal muscles and back into the brain is going to be the biggest mass change in the whole nervous system that I can see, because it's just going to change the amount of sort of the volume of nervous electricity is changing a lot, and that's going to probably influence the gut as well. I've seen a lot of clients with enormous tension across the gut here, and just letting go and dropping that, which of course the diaphragmatic breathing can help as well, seem to make an incredible difference. So that's where I start generally, and building that sense of agency. I can do something, self-efficacy, and the changes that kind of come from that, and then maybe getting into the self-hypnosis. But that's generally my general route. But it might be acceptance first of all with somebody, because they're struggling with their symptoms so much.
Yeah, so it's as I say again, you can't have a fixed protocol how you do things. You have to be flexible. You have to have some intuition as well, and yeah, you're also learning about the person. So it's not something that is a constant feedback loop that you're getting, and it's not I'm gonna do this because of this and this, and it's you have to be flexible.
Getting the information, and when I've told this story before, a young lady that came for me for IBS, and she was very clearly very tense as well. And we started with but really the main thing was she was extremely low in assertiveness. And we worked on 4 sessions just for her to talk to her counselor, who she'd seen for 4 years every week with no goals, anything, to actually say to the counselor, I'm not sure we need to continue doing this. Took 4 sessions to talk to this lovely old lady about it, who was then, oh, of course, that's fine, love. Just blows my head. And then her relationship with her parents was so dysfunctional. I mean, it was like, and every time I kept saying, let's focus on the IBS, she goes, no, I want to work on these skills, this, basically self-express, assertiveness. And that pretty much resolved it. It was really interesting. She didn't really want to do any work on the gut. It was all about her social skills, essentially, which was just fascinating. Yeah, and it was seriously messed up all over the place. So, yeah, but as you said, I wouldn't have known that and I kept wanting to go back to this. I said, I know you come for IBS, and so this is the treatment goals of this. Let's come back. No, I want to focus on this. So, being guided by the client as they're becoming more aware, of the whole biopsychosocial aspect of their lives. And interesting. Let's have a look at a few questions here. In the anonymous attendee put in the Q&A panel, amazing presentation. I'd love to hear from both of you about how you feel this information is applicable to cognitive behavioral hypnotherapists that are not doctors. So let's talk about that for a moment. But also, I'm super cautious with regards to my sphere of competence as an early career therapist. I want to hear if you think some of this can fit into the practice of regular therapists, given the prominence of IBS in the general population. Or any tips, considerations before you take a client with IBS on the ethical, medical, practical side. So let's speak to people trained in our model, at least for now, in terms of how you see their sphere of competence and how they could work with this. And I would want to say, by the way, everyone, I think this webinar is not a training in IBS. We're touching on the topic here, and we do aim to develop a workshop. I hope we're going to be discussing that, because I really do want to offer a specialist workshop on this. But yeah, over to you, Dr. Elena.
So I think the first question, and this is what I do as well, because I have to make sure that what I offer people is not medical. That is very clear, because I am not offering private medicine through this platform. So for me, and also probably for anyone, my screening questions are: have they been diagnosed by a medical professional? Has there been any change in their symptoms in the last 6 weeks? And then I check the alarm symptoms that might indicate that there is probably an organic problem or a structural problem, which is bleeding from the back passage. Having had a recent change in bowel habits, so I would say at 6 weeks, that's something's changed. Where they have weight loss without unintentional weight loss. If they've had blood tests and they showed that they have iron deficiency, that is something that is to be investigated. And also, one of the symptoms, having symptoms at night, or severe pain that is progressing and getting worse. Those are things that should raise alarms if someone hasn't been investigated, because you have to make sure that there's nothing medical going on. Apart from that, I think also assessing their anxiety levels, so doing your questionnaires straight on and making sure that they're not, sky high on anxiety that requires medications. Obviously making sure if there is depression again that's managed. And apart from that,
Suicidal, have you, I know Professor Peter Wall said 1/3 of his clients had fairly intense suicidal ideation, much higher than cancer patients generally, that it can be, depression and suicidal ideation can be quite a big thing.
yeah, I think the suicidal ideation it has been it's been in studies. Yeah, is 1/3 of the people that turn up in a tertiary center, so that's a specialist center. So obviously you can imagine that they probably have gone through a lot, and I think that's an old study, but it might be something that you need to check and make sure that, obviously, if you are spotting that there is a problem, you need to ask that question. In terms of other, for sphere of competence, I think making sure that you understand that if something is not working, understanding why it's not working, and if it's something that you think is organically going wrong, then obviously that is something that you need to refer back to their GP, because sometimes people do have something brewing and they don't know it. But apart from that, I think is the therapies that we use are quite safe. So yeah, it's hard because I think once you've asked the screening questions, whether they have been diagnosed with something's changed or whether there's any alarm symptoms, I think then you can say, okay, I'm pretty sure if it's been diagnosed by someone, that is IBS, and yeah, by a medical professional or someone.
Has this been checked by a medical professional, a GP or a specialist? When did that happen? Has
Yeah,
anything changed? How long ago was that check done? Has anything changed in the meantime?
yeah,
And then
yeah,
using your smarts to basically say, you should probably go back and get that rechecked before we proceed.
yeah. And also, the specific type of the diarrhea predominant IBS, it can be a lot of different reasons, and sometimes that might require further investigations. But again, it's something that you probably suss out if things are not going right, and there might be something that needs to be investigated further.
I mean, I think we're talking about, you're offering services as a cognitive behavioral hypnotherapist, as a hypno-CBT therapist, and you're not advertising that you treat IBS, but somebody comes up and says, "Can you help with my IBS?" So there's a question there about, I mean, apart from those initial checks there, there's a question there about having not done any particular focus training. You probably could, but it might be better if you can find somebody. You probably could, and work with your supervisor, and you could probably help some. It will be much better if you've done a specialist training on this to apply it. But whether you should, it's an interesting. If somebody, I mean, I think I would probably, I wouldn't say, but you probably could help. And if they've come to you and and they're working with you, there's some help that could be given. But it would be better if you'd actually done, and not to advertise your services if you're not trained and have
I,
a
th-
supervisor in this approach.
I think being honest about what you can help with, because there's a lot of people that just will take anything on board and just,
Yeah.
try. And I think being honest with them and say, look, I haven't worked with a lot of people about this, but yes, we can try. That is one way. But yeah, I would, if you're not comfortable or understanding the problem yourself, then it can be tricky. And I think that might be that you can get some supervision, or you get extra, or you refer to someone that does specialize in that.
Yeah. And I think, obviously, I think if people are quite strong on the CBT side from the point of view of like health anxiety and understanding safety behaviors and perpetuating factors, they're probably even if if they bring that knowledge to working with IBS with some relaxation and hypnosis, they
Mm.
could probably help. But I wouldn't go so far as to say I wouldn't recommend advertising services in that area unless you've
Mm.
built up a whole, you really have an experienced sphere of competence,
Yeah.
or trained in that. So I hope that helps anonymous attendee there. Olya says we often talk about mental health affecting digestion, but I wonder about the reverse. Does impaired digestion or gut dysfunction play a causal role in mental health difficulties through gut-brain axis?
Yes. So is a two-way. It's so people that have anxiety and depression can develop IBS, and people that have IBS can develop anxiety and depression. So it's a two-way thing.
Yeah, definitely back and forth. So, and Sarah says, what are your views on the current fascination with the vagus nerve and vagal nerve gadgets that came to cure IBS? Yeah, that's why we talked about the vagotomy, just to put the vagus nerve people all on edge. Um,
I think look, the vagus nerve is something that connects the brain and the gut, and it's what we use is the rest and digest. So in terms of gadgets, I'm not sure what gadgets people talk about, but I don't usually deal with the aspect. I don't recommend any of that. But yeah, I
I
would
think
have
there's
to
a
look
lot of
the evidence
fascination with it.
around it. Yeah,
People
I
think
would
it's
have to look
always
at the
this now
evidence.
this secret thing that calms everything down and brings peace and calm and balance to the system. And of course, there's a lot of fascination with the heart rate variability. I mean, the question for me, Elena, was always, well, I can see the sympathetic parasympathetic balance is critical, but
Yeah.
how on earth do we measure that? Because it's just, and so people think that heart rate variability became a window, and I believed it for a long time, into the balance. But my reading of the literature now, because I'm in touch with Paul Grossman, Dr. Paul Grossman at Basel University, is a psychophysio researcher who specializes in this particular issue, is that the vagus nerve controls lots of stuff, and that
Mm.
heart rate variability is simply working on the lung heart function. That's it's not even doing a particularly good measure of that particular aspect. It doesn't reflect all of the down regulation function of the vagus nerve, which does a lot more than just down regulation. So it's just yeah, he's published recently on that quite strongly, that heart rate variability isn't a window into how the whole the sort of dysregulation of the nervous system,
Yeah.
and that we don't really have a window into that particularly, that we can look at and go, here's the measure of it and here's a device to adjust that. And
No, and I think, just you doing your simple things work. We know that the breathing techniques work. So why would you go to something invasive when you can help in a different way?
yeah, yeah, and I'm sure there's massive placebo effects in those devices. We know, and also we haven't talked about placebo responsiveness, but IBS is very placebo responsive.
It can be, yeah.
Yeah, I think we got pain and then anxiety, depression, and then IBS is like quite high up there. So providing a plausible protocol that people believe in, have positive expectations about, with a caring professional in itself, is probably going to influence a lot. Sarah also asks here, how do you address food fears, behavior experiments, imagery? What seems to work best? That's a great question.
So food fears depends on what the situation is. Is it food fear when they're going out, or is it specific foods that they been told by different other people that that's a problem? Um, I think trying to get an idea of what the problem is in that situation, and is it the actual food or is it their reaction, and just try and target that aspect. You could do a sort of gradual exposure to things. It depends. It depends on. It's hard to give like a clear answer. You have to conceptualize the whole problem first before you start giving them the treatment.
I think, I mean, there's a difference between people who have developed food fears and then are avoiding those foods, And then, and that's one thing. I remember having one young lady who'd done the York test, and she'd been told that she was
Um,
allergic to 370 foods. She was rapidly losing weight. Unfortunately, she lived in Bristol, and it was a 2 hour. I mean, it just was not practical for me to continue to see her. But it was really, and there was whole relationships with the mother problems. I mean, there was just a lot of stuff going on there. And when you see people and they're rapidly losing weight, it's quite a concern around this food fears.
mhm.
Um,
I think if you see someone that are losing weight is something that you should not be dealing with. I think you
yeah.
should either refer to an eating disorder specialist if that's definitely the diagnosis, or to a dietitian to review the weight, and to the GP to make sure there's nothing organically happening, because that's not really within your sphere of competence. Um, but let's talk about the allergy testing, because um, I'm fed up of people being scammed by some of these tests. I'm going to be very honest about it. So there's a lot of people that go through the tests, and the test, you have to make sure that the test that they're doing, so is the testing for IgG, which is the immunoglobulin, which basically it doesn't tell you you're allergic to it. It tells you you've been exposed to it. So that's why it comes back as I'm allergic to 300 things, because it does come back like you've been exposed to all these things. It doesn't tell you you're allergic to these things. So I think people get the wrong information, and that can be part of the problem. And I think as a tip for patients is make sure where you're getting the information from, and that is a reliable information that you're getting before, because otherwise you can end up in a lot of different problems.
I do think there's a lot of alternative, complementary alternative therapies out there that are potentially not just taking people's money, but actually making things worse. I don't think the people doing that are bad. I think there's some kind of self-deception that's gone on there in terms of they think they're helping, but they don't really understand the way in which it's not. So I think it's a problem.
I think, yeah, it's sometimes we lack the evidence, and that doesn't mean that something doesn't work. However, when we're trying to get ahead of things and we claim things that are not substantiated, then I think is where the problem starts, because we can give false hope, we can give all this hype, and it's just the wrong thing that someone, because then it can end up in someone getting whatever they're advertising, and then they're getting frustrated, they feel shamed, and it can create another problem, and not actually getting something that's got evidence, numbers needed to treat
Hmm.
2 or 3. I
Yeah.
mean, what else do you want? It's yeah, it's simple. It's giving the right information at the right level so people can understand it, and they can make, everyone has their own autonomy, everyone can make their own decisions, everyone's body is different, everyone, as long as you make an informed decision, that's all we want people to do, because at the end of the day, I'm not here to change people's minds, but as long as you understand what you're doing and the evidence behind it.
Mm. I think the food fears thing is interesting as well because even without sort of the York test type stuff, feeding people develop, they've just had these different reactances to things, then they focus in on that more and more. And I found it quite interesting doing just a little kind of imagery-based recall situational analysis of what it's like for them
Mm,
preparing to eat food, eating food, and
mm,
afterwards, and them noticing their level of tension, thoughts, etc.
mm, mm.
And just being
Uh,
just being relaxed when they eat.
yeah, yeah, that can help.
Um, Sarah asks here, and I think this is interesting because we have mentioned this, Sarah, but I think we should really go actually over this whole thing a little bit more. It says, can hypnotherapy help people with, I think you mean other functional gut disorders, like IBD, but that's not an info. We've just covered that it's not. But I think we should just say broadly, I mean, what are the other types of disorders that hypnotherapy could help with? Because I mean, I think some of the sort of the chronic pain disorders in the gut, it can help with.
Mhm.
I don't know about, you know, IBD,
I,
Crohn's? I mean, what are some of the other sort of chronic symptoms people have there that it might?
I'll tell you where the evidence is. There's evidence about the non-cardiac chest pain. They're starting to have that. There is evidence on the cyclical vomiting that can help. And there's evidence. There's one more. Sorry, I've it's gone from my brain now.
That's okay.
I'll find out and let you know.
And people, if people came with like they've got IBD, they want some hypnotherapy to help Crohn's, they can. What would be your view of these sorts of
Um,
requests?
IBD is, I think you're gonna get out of your sphere of competence because IBD has a predisposition for someone to have flares of the disease. So you don't want to treat something that you don't, let's say if pain was predominant, you don't want to bring the pain down to a level where they minimize the pain constantly because it might be an alarm, that something is not right. And
Mm,
especially with Crohn's disease, pain is part of one of the things that people need to have investigated. So we do know that there is anxiety and things can help, but I think you have to have a little bit of knowledge and making sure that if you take someone on, they're still being followed up medically and they have the right support. Because if things start going wrong, they definitely need probably the right medication, especially with Crohn's disease and ulcerative colitis. They might be on the biologic agents that require further treatments or further intervention. So I think inflammatory bowel disease, there is evidence that it can help, but I wouldn't, if it's someone that you haven't had the knowledge behind this, I wouldn't take them on.
mm. I think that and yeah. Well, I mean, there's the stuff that might not be going on that that you don't know might be going on that you don't know
Exactly.
about. The other aspect is also not offering hope. Where I mean, the extent that people can learn some relaxation, acceptance, stress related triggers, and post stress triggers, and that being all managed better. I think we could say that there's help that could be given there, but it needs to be
Mm.
understood that the fundamental symptomology probably can't be. I mean, is that how you would phrase it?
Yeah, I think teaching people skills is good. But I think it's hard because you have to understand what is a flare in ulcerative colitis and IBD so that you
Mm,
know that that is a flare. So you don't want to minimize symptoms that might be the beginning of a flare, if that makes sense. So I think it's hard to, if you don't have the knowledge, it's hard to go into that aspect and follow up someone that does that because it's hard because you don't want to give false hope as well. Yeah.
yeah, I think that's you could offer more hope around IBS than around. So I mean that kind of but
I mean,
yeah,
there
I
is
think it's always
don't get me wrong, there is evidence, but as I say, it's if you haven't got the knowledge behind, I think is a little bit of a dangerous field for you to go into
yeah, yeah,
because
yeah, yeah, yeah.
yeah, that's what I'm trying to say. Yeah.
So I think we've covered most of the questions here. And Dr. Paul Grossman is the guy to look at on the heart rate variability, but also his um, aim to really try and look and see if there's any evidence for polyvagal theory, which is this thing that's out there and is very tied in vagus nerve. Have a look at if you can get on ResearchGate, any of you. His work there is fantastic in terms of the project he's been running there. Lovely guy as well. So Elena, that's fantastic, and yeah, I just think we need to put together a workshop on this and help people because there's so much opportunity to help people. And I
Yep.
think that's the exciting thing. It's really, I mean, it is really an effective approach. And this idea of bringing both together, hypnosis and CBT in an integrative way, and bringing all of that. I love the way that you're just curious to see kind of figuring out what's going on here and how to put together a treatment plan. And yeah, we'd love to hear from everybody who's interested in a professional training in Hypno-CBT for IBS that we'll be talking with Dr. Elena about
Let's
because
do it.
yeah, let's do it. We've been wanting to do that for a long time, and I think it's just exciting. And I think the IBS clients I've worked with have been some of the most grateful because it just turns their lives around so
I think
profoundly.
I think it's one of the most misunderstood conditions, and I think a lot of people struggle in silence. And there's a lot of stigma, there's a lot of shame. Bowel problems don't get the sexy appeal that other disorders have. So I think it's important that we do help people that struggle, and it is a very common problem. And if anyone that has IBS watching this, it's a completely valid diagnosis, and it's just there are ways out of it. It's just finding the right person to treat you.
Fantastic. So watch this space, everybody. And if you're looking for treatment, I think Elena, you be happy for people to contact you.
Yeah, sure, no problem.
Yeah. So and then as we move through this and develop a workshop, there will also be ongoing supervision as part of that, because that's an important part of people developing a specialist sphere of competence, I think, that have a specialist supervising. So yeah, we'll make sure we're doing this kind of very thoroughly. So yeah, any questions, send them in. Do be in touch. What's your website details? Should we pop them in here?
Yeah, I'll do them in.
We'll do. Okay.
I'll do it. Let me just see, and then the website is just the
gutbrainmetamorphosis.com. Fantastic. All right. Well, thank you so much, Elena. That was great.
no, thanks for
Love talking
having
with you
me.
about this. And for me, it's just, I love just seeing the way you think about the problems, and that I know we played a part in kind of giving that framework of being able to look at things. And so that makes me really happy seeing this sort of hypno-CBT in specialist application. Yeah, fantastic. Fantastic. So, yeah, let's continue this work together, continue the discussion. Thank you all.